Hello, everybody. Good evening.
Hey, so yeah, and you're gonna. We also thought this would be an opportunity to kind of use some cases and a little bit of the technology with ortho bullets. So I'm gonna do my best to follow along with you. I've realized I have two logins, one in my computer and one on my phone, and they're come from different emails. So I'm gonna try to do my best to work with that. But we'll also have a good, robust discussion on these. So I'll let you take it away and I'll help moderate.
Great. Thank you, Jeff. Thanks again for the invite tonight and allowing me to share a couple cases here. So can everybody see the screen?
We can.
Great. So once again, good evening, everybody. It's pretty late here on the East Coast, in the east part of the Midwest right now. So you guys are a little lucky being on the West Coast right now. But you know, this is a case presented by with ortho bullets and kind of an interactive platform. You know, we've already gone over multiple cases tonight, and you can see how they've been very challenging in different ways to fix certain fractures and reduce them, and different treatment options. And so here's the one using the platform about a proximal humerus fracture in a 61-year-old male. And I'll just kind of start showing some of these x-rays here for Jeff. And, you know, this is a lot of times we're using this interactive platform for residency, like morning conferences, as well as to review certain cases, especially dealing with certain topics, such as like proximal humerus fracture on this one. As you can see here, you know, we have a, somewhat of a accommodated proximal humerus fracture. It's a 61-year-old right-hand dominant male. Here are just a few of the x-ray views. So I don't know, Jeff, if you have any comment on any of those x-rays or any initial thoughts. He's otherwise healthy. He is a smoker. He continues to work, lives alone. Is this something you're thinking about? Fix, replace?
I'm leaning towards fixing the right hand dominance and a right proximal humerus fracture. I worry about smoking or anything that might interfere with his outcome, but it's not an absolute criteria. Certainly might be some opportunity for counseling, but and I'll treat proximal humerus fractures non-operatively. It depends to me a lot on patient expectations, minimal comorbidities, and a fracture that I can fix.
Yes, I mean, on this Nets team. As some of the polls that we ask for this type of case, right? One, like first poll is like, do you want any additional imaging? And this is an interactive way. So Jeff, I'm asking, are these x-rays enough to make your treatment plan, or would you want something a little bit more?
They actually are. If there's more comminution, it's not going to impact what I do in this particular fracture. And so I chose no additional radiographs.
Yeah, and we sent out this case just this afternoon to the orthobullets community to try to get some feedback as well for some answers to the polls. And you can see here about 50% of the people who voted already, so of 475 agree with that. And when we're kind of going over some of this, people are going to be like, well, okay, is there any evidence to support your answer, right? I mean, are we just kind of, is this the way we were taught and that's why we're answering, A, B, or C? Or is there actually any evidence? And this is one of the interactive features that we're developing here, where you can kind of see what people are choosing. Say if there's evidence to, for, or against, you can see these minus and plus sign. So if there's evidence against getting extra x-rays, you can actually put that in. Or if there's evidence for. So this is just a really nice interactive feature.
I like that. You mind if I interrupt you there? Because I didn't know that feature. I knew the feature where after I commented, it pops up whether I want to add evidence, but I actually didn't know I could scrutinize whether I was searching for or against. That's pretty cool. And it's just a matter of clicking that minus button and the plus button.
Minus and plus, and and when they already have something like this, so if you see -0, +0, so that means we call this an evidence battle. It's really, we don't know the answer yet, and we're trying to figure it out. So say, for example, I push on this button here. It's actually going to, people have added these articles already, okay? Because this is where they can get, keep track of things. And you can see here, this is just an algorithm created about, clinical impact versus cost effectiveness. And you can see here, so this article, people are saying there's a little bit of clinical impact, but there's only been several votes here. So you can see they're pending minimum votes, 12 of 28 responses. So we're not trying to make it's like polls, if when we watch the election, right? Like, it's too early to call a state. This is too early to call this answer. We want to have, at least 28 responses, but you can, click on this and it'll take you to the article on the site, and you can even then vote yourself. Like, there's regarding advanced CT visualization, improve the accuracy of orthopedic trauma surgeon residents in classifying proximal humerus fractures, a feasibility study. And you could say, okay, this article does or does not relate. Is this increasing cost effectiveness? So if you're saying, if it says we don't need CT, maybe that's showing increased cost effectiveness, or maybe you don't know the answer. And you kind of get the point here about, submitting, and then it becomes part of the data point here. And it gives us another feedback mechanism that we're, trying to do things that are more evidence-based. So that's just one of the examples here for this type of questions. And we mentioned, how would you initially manage this patient? So Jeff, I'll pick on you since you're the host.
I chose operative in this situation.
And like you said, you can add evidence if you wanted to show that maybe proximal humerus fracture age population.
Yeah, I'm good today. I trust my brain on this one, but it's great that I can look that up.
Yeah. And you can see here that about, we're definitely leaning over about 2/3 of people are saying operative fixation. So definitely going with the trend here. So how would you fix this, Jeff? We went back to proximal humerus fracture, right hand dominant male.
Well, I definitely think it depends on what you're good at. And I spent a decent amount of my career doing nailings of proximal humerus fractures, and I certainly would consider that as an option. But as I wax and wane, and depending on which fellows I work with, because I do a little bit of trying to teach people what they don't already know. And so I'm in a phase of doing a lot more proximal plating and doing it in ways that are allow for early motion, and it's not just filling all the screws.
Yeah, so so here, I'll, maybe, so you would say ORIF for this one?
Yeah.
All right. So you can see,
and actually,
here,
I want to see the data here. Yeah.
64% of respondents are putting ORIF, 23% nail. So those are the two, obviously top choices here so far. So right in line, I guess, with the orthobullets community going for this.
Okay.
And then choose, in terms of, I guess you didn't choose a nail, but then there's going to be short and long nails and so forth, just like we have for femur fractures. So obviously I'm going to show what I did here for this case. I did a short humeral nail. Let me see. Oh, I guess I already voted for that, so it's not letting me vote. So short humeral nail, about 29% of people said they would do that. So I'm going to go back just down right here to the intra-procedure, some of the fluoro views here for this case. And, I always always harp on the residents and fellows and so forth. I always get just like the traction views we saw with the distal humerus, I'm doing a very similar thing. I always want to make sure I can image a proximal humerus fracture. It just seems like there's always some magical metal bar that pops up during the case. And I'm like, where'd that come from, right? Or a magical lead, right? Where you don't need it from the EKG, from the anesthesiologist. So always watching out for that. So this is just, pre-op or, intra-op pre-procedure films. Here, I decided, like I said, to nail this. I think, basically every bone can have a nail. I started doing some of my bunions now with the nail. So if it can have a nail, it gets one. And this is a, fracture using joysticks. We
I
mentioned
like
this.
that. Yep.
You
That's a technique that I use for nailing too. Yeah, it's awesome.
Yeah, and it can really help you get the starting point. And also, I use this joystick too because you kind of looked on the pre-op X-ray. There might have been something with the greater tuberosity. So I want to kind of pin that as well. But it's nice to really deliver the head to get a straight starting point here. And that's, the nails getting inserted. That K-wire was basically out of the way. And here's just a short proximal humeral locking now, and so forth. And, Jeff, are you starting?
Go ahead.
What's your rehab protocol if you plate these fractures?
Early motion. I'll already start Codman's right away. And sort of what was alluded to in the distal humerus. I mean, you do have to appreciate your patient, quality of bone, and different things like that. But almost everyone gets at least Codman's right away. And within a week or two, I'm usually progressing that range of motion based upon their progress. And I would do the same with this nail as after one of my plates, probably.
Yeah, and I'm pretty similar with that as well. I try to start early range of motion, but I'm not as aggressive with weight bearing on this. I haven't jumped that far yet. But
I actually think mechanically there's a difference also between weight bearing and lifting. So I do lifting restrictions, and nails and some platings. I am still cautious with weight bearing, but range of motion to me is a third type of activity with different forces. So I think all three are a little different.
Yeah. When do you allow weight bearing for your nail or your plating for proximal humerus?
Is dependent a little bit on bone quality and some patient factors, but I'd probably be talking to them about, for a proximal humerus fracture, more after 4 to 6 weeks.
Gotcha. Yeah, I'm usually, once the wound is healed and so forth, and, about a month later. So pretty much on track with you. So this patient, there's a little surprise here. So he called in because he started having, more shoulder pain and more arm pain after another fall. So as we talk about trauma as a disease, he fell once, he fell again. And here we have, this is what we're, have it about, he's about 2 months post-op.
Ouch.
Doing great.
I wouldn't have expected it. He looked like he had pretty good cortices, and that's a factor for me. And so I would not have anticipated. He probably looks like it was related to a significant fall.
Yeah. And what would you do now? You saw that this fracture, peri-implant fracture. How would you treat this now?
So it's tricky because if I nailed it in the first place, and I might have at one point in time, and I have there are enough different approaches, and there's a difference about the angle and access that I don't really do anything as an open nailing. I do a nail or I do a plate. And so if I got to take this nail out, then I have to convince myself that I'm now going to do a whole nother incision to put a plate and screws in. So it's not that you can't combine that. I mean, totally doable situation, but I might consider exchanging to a longer nail. I wouldn't fault somebody and I wouldn't fault myself if I converted to a plate at this point in time, but now you're starting to think the next fall. And so, is the plate going to be long enough to address the next fall, or is a nail even going to be long enough? And at some point, I would say in the humerus, it's one of those challenges where you're never going to prophylax them all.
Yeah, excellent points. And that was going through my head, it was about, how to treat this, right? And, I chose revision IM nailing, and it sounds like maybe you would have too, if you would have initially nailed this at least. Mm-hmm. So here looking at the poles, we have, you could see how the wide range, right? Like, and this is kind of like a, trauma conference, right? People are going to do multiple there's multiple treatment options, and there's really no agreement. And so this is a thing that, we got to, kind of learn where is there evidence, if there is even evidence for these things. But you can see that wide range of, basically 4 different options. So, I chose revision IM nailing, and this is one where I did open it. He was about like a week or 2 out after, by the time he got fixed. I did open this, and I will many times, if I'm nailing a humeral shaft fracture, I will make a small incision to sweep the humerus to make sure that there's no nerve interposed.
And just to qualify my comment earlier, it's not that I wouldn't do an open nailing, but just, the proximal part of the incision isn't necessarily easily accessible from the same skin incision for the proximal part, right?
Yeah. But yeah, so, but I'll sometimes, like I said, make that incision just to sweep the nerve. I don't know, are you doing that if you ever nail a humeral shaft, or are you just still doing it completely closed if possible?
That's the thing that started converting me in some shaft fractures to when I would plate, because I was a big nailer. And if I was going to open it anyways, I just opened it and plated it. And if I wasn't going to open it, I nailed it. And I typically did not explore, but I used a lot of caution as to what I did around the fracture site, and with reamers and things that I'd pass. And I just say it's a concerning technique about the nerve with certain fracture patterns and where certain nerves can be. But that's what I did.
Yeah, I think, yeah. I'm still pretty OCD about the nerve, where on most of them I'll make a small open and just to sweep it if I'm going to do a longer nail. And I never ream also in that area. I will push past with the reamer. It's just kind of, more anecdotal evidence, I think, than borne out in any literature. But so he got a long nail, as you can see here, and then he did all right. Hasn't come back with the 3rd fall yet, but still waiting. There's ice on the roads here in Indy tonight, so we'll wait and see.
And this is a feeling on my part, because I'm curious, like, now that you've done a lot of this, so what is the approximate size of your mini incision to explore the nerve? And are there pearls or tricks as to how to easily identify it to make sure it's out of the way? Because to me, that's a bigger incision.
Yeah, I'll make it a lateral incision at the level of the fracture, and I'll sweep down, like, bluntly, and just literally take my finger and posteriorly make sure there's nothing there in the fracture fragment when I've reduced it.
Okay.
And so it's only a few centimeters, but it is an incision at the fracture site. I mean, I disturbed the hematoma, but I'm not putting any retractors in, like any homins or anything like that. It's basically, I'm just using my finger in my hand.
So it's a finger to feel the absence of the nerve, not a finger to actually 100% of the time feel the nerve. Am I getting that right?
You are correct. I'm just feeling the bone. Right.
Okay.
I don't feel I'm not like trying to feel for the nerve.
So, and I will say anecdotally, the one case that freaked me out the most in my career was one that was pretty high energy that I was nailing, and it was open, and I did explore it because it was addressing the open wound. And this is one where I was doing that and nailing. And in 2 parts of the procedure, the nerve was on different sides of the bone. So on one time it was posterior, and then I either the guide wire or did something. And then I realized that the nerve was on the anterior side of the bone. And I was like, okay, how did you get there? And what would have happened if I didn't recognize that? If it was halfway.
That might make me change my practice too.
So it's that I'm saying it's totally possible with anyone that's doing extra care for the nerve. I totally get it.
Yeah. And here's just another, feature where we're, putting on videos that, are like, for example, from pushing the envelope in 2019 for proximal humerus fractures. So, they could be, helpful review if it when they are related to the case as well. And just more evidence. So these are the evidence articles that people have already uploaded through, like, when they're answering a poll. And so you can actually just see, this is a synopsis of all of them. And you can click on them, obviously, to get more information, look at the abstract and conclusion and so forth. So it kind of gives you just a nice little, like, not case library, but a little library of journal articles that are relevant to proximal humerus fractures that everybody's utilizing. So we're trying to really, encourage that, because, we want to base our decisions hopefully off some evidence. And, see, and a lot of times we don't have good evidence, and that's what we're realizing.
Yeah, that's excellent. I have used the feature where I blindly just do the search function for the evidence myself and see what comes up. But I do like, in my busy or very full practice right now, where if I can go to this and find what other people thought was useful first and clicking on that to do a quick read of something, I find that function quite helpful.
Yeah, and I got a question for you, Jeff. When you used to nail more proximal humeruses, did you think about the rotator cuff at all or anything? I thought this article, somebody uploaded this. I thought this was pretty interesting, at least.
What was their conclusion? Because I was taught, and I trained with a lot. I trained at the Camel Clinic, where we did a lot of nailing of a lot of fractures and got really, really good at it. And then I went for fellowship, where there was a lot of plating. So I had to got a lot of scrutiny for my opinions on nailing. And even after that, early in practice, when I was doing a lot of nailing, people kept telling me I had to open everything to split the rotator cuff and repair it. And I still that just never made any sense to me, that a round hole in mostly a musculotendinous portion would have any impact, even if it was even close to the very tendinous portion. It just doesn't make any sense to me that would leave a rotator cuff injury. They might have some symptoms of rotator cuff irritation, but to me, I didn't do a lot of open stuff. I did it pretty darn percutaneous, even trying both. I did both and didn't find much of a difference.
Yeah, I agree with that. I mean, it's, I don't know how much it makes a difference too. And we do it in other nails, right? I mean, whether we don't think we always get part of the gluteus medius, I think when we're nailing, a femur fracture and so forth, or whether we go through the patellar tendon or something. But they found the conclusion, supraspinatus tendon lesions after IM nail with the third generation humeral nail were rare, 12.5%, and asymptomatic. Prevalence was not higher than in the general population in the literature, which was 16%, and I didn't go really into this article, but it's interesting. So it almost says that you had a better rotator cuff if you got nailed, which I find that hard to believe. But I think it's one of their conclusions was basically they thought many times it's due to technical error, and I can see that. And I think that is with anything, with any type of nail or any type of procedure, whether it be plating, nailing. If you don't respect the soft tissues, you will have more iatrogenic injuries to the surrounding structures. So, but all for those people who say we hate the rotator cuff for nailing, I think this is at least some evidence to support that it's okay.
Well, and I like the mission that you described, is that we need to see where our deficiencies are in evidence and how we want to add to it, because I can't make an evidence-based argument for my opinion. But I did do a lot of comparison and nailing and plating way back in my fellowship and followed that issue for quite some time. And like many other injuries, the choice of the direction of repair will determine the potential for postoperative symptoms, right? So if you do troch entry piriformis, you're going to decide what sort of risks and complications you might have with that. You do the suprapatellar or standard infrapatellar, and same thing with nail versus plate. Plating has more elbow symptoms in some aspects versus nailing. So, and the data shows a difference, but you have to then decide, is it clinically relevant? So that's the benefit of us continuing to explore and continue to use our skills of how we take care of fractures and how we treat them, and being able to compare and continue to learn.
Yeah, absolutely. I mean, it's a kind of continuing lifelong learning, right? The more we know, it's actually the more we realize we probably don't know. But yeah, so it's also like here, like, just speaking of the rotator cuff for this type of, proximal humerus fracture, you can also see already just, for this case, there's been 44 views that people have clicked on. So people are, at least interested in, like, are we actually doing something to the rotator cuff? I think at least maybe reading into that data a little bit, but it's a concern for us. So
excellent. We'll use a couple more minutes to wrap up on this section. If you want if there's like another feature either with this case or another case that you want to show, or just an interesting teaching point that you want to share with our audience, that'd be great.
Yeah, I think another teaching point, I had one more case, but I know we're almost running out of time here. It's just, we're talking about like pathways. So this is another, if you click on proximal humerus fracture pathway, it takes you to the proximal humerus section, where there'll be more cases, questions, evidence, videos, and so forth. So I think that's just a nice thing as well. When you're, posting these cases or you're looking at it, you can kind of look and see if there's other similar cases, regarding proximal humerus fractures, some of the, basic information that we're all, a lot of times, whether we test on or, ask our residents or fellows questions. And here too, hold on, let me just minimize my screen here. So evidence footprint. This is like, so when we get that data with all the articles, so once again, it's our, we call it clinical impact increases to the right, and also cost effectiveness. So you can kind of see how many articles people have uploaded, whether it be from, or the questions that we have, or from cases. And you can see, okay, the blue ones obviously have more data, and you can kind of then, even click on that and try to see, sorry, my internet's, I think, a little slow, but, see, randomly the Proffer trial, okay? And it just shows you, okay, how people are voting. So on that article, and if you look, that was, it was relatively high clinical impact and cost effective. And it kind of got pushed into that quadrant. So it's a really interactive tool to see how everybody's interpreting the evidence that we're getting from all these different sources that we have.
Excellent. Let's see, I haven't been following the Q&A. Yeah, I think just Emil is commenting, most older patients have a degenerative cuff that they have accommodated over time. So a sudden injury like an 8mm hole in the tendon can bring out the painful version of it that the patient did not appreciate before. So that's a point, because the patient may assign that new pain to you or me if we're nailing. But, just highlights that, one of those things that we see on a regular basis, where somebody's pain is brand new and we know the condition that they have has been around for ages, whether it's a fracture around some arthritic disease or a few other conditions, right?
Yeah, exactly.
Well, yeah, and that was awesome. Thank you so much for sharing that with our attendees. I think that was educational, hopefully in the clinical realm, as well as a resource for looking things up and adding to our global knowledge base, but also individually, just I can look that stuff and improve my knowledge with a few clicks.
Great. Well, thank you, Jeff. I really appreciate it.